Hello everyone, I'm Dr. Angela Mattke and you are watching Ask the Mayo Mom on Mayo Clinic's Facebook Live. Twice per month I host this show where we discuss common pediatric health topics with top experts from Mayo Clinic Children's Center in Rochester, Minnesota. It is Congenital Heart Disease Awareness Week, and congenital heart defects are the most common birth defects in the United States. They affect approximately 1 in every 110 infants. That's 40,000 babies each year in the United States. It's estimated that approximately 25% of children born with congenital heart disease will need heart surgery or other interventions to survive. For some types of congenital heart disease, the surgery is not a cure, and this includes our focus today. We will be discussing a severe type of congenital heart disease defect called hypoplastic left heart syndrome, also known as Hlhs. My guest today is Dr. Tim Nelson. He's the director of the Todd and Karen Wanick Family Program for Hypoplastic Left Heart Syndrome. He's also an associate professor of medicine and pharmacology at Mayo Clinic. Dr. Nelson, along with a multidisciplinary team of physicians, scientists, and many other experts, are working collaboratively both here at Mayo Clinic and across the U.S. to form the Hlhs Consortium, with the goal to find and apply innovative solutions for the treatment of hypoplastic left heart syndrome. Dr. Nelson, thank you so much for joining me today and coming back again. I know we had this similar discussion last year, so thanks for being here.
Yeah, my pleasure. Thanks for having me. It's a great week to be here with the awareness of congenital heart disease.
It is. There's a lot going on, actively, both, with things live events, and there's also a lot going on in social media to help support families and raise awareness. So hopefully we can contribute to that today.
Great.
Absolutely. Well, let's get started by talking a little bit about what is hypoplastic left heart syndrome for those watching who may not know, or just to bring it back in reminder what exactly is happening with that anatomy.
Yeah, so hypoplastic left heart is a severe congenital heart defect that affects the left side of the heart from developing. So hypoplastic left heart means that the main pumping chamber of the left side of the heart doesn't develop, and therefore requires 3 open heart surgeries for these children to develop a new plumbing out of their heart to allow their heart to function after birth. So before birth, they're just fine and they do well because they're largely dependent on the right side of the heart. But within 3 days of life, they require their first open heart surgery to be able to start reconnecting the plumbing and allowing the right side of the heart that they do have to now do the workload of the entire body and the hearts, which is not normal for you and I to have one side of your heart having to do all of that work.
Absolutely. I think we have a nice diagram here. We can take a look at it, and you can give us a little description here about what we're seeing.
So this is a slide to show that we can make this diagnosis in utero. It's commonly done with a routine screening ultrasound as demonstrated here. And you can also see that on the normal heart on the top, you have the 2 chambers of the heart, the red and the blue, but on the bottom chamber, the blue heart or the red heart chamber, the left side of the heart, is actually small and is not large enough to sustain normal heart function after the baby is born. And so this is diagnosed there, and that allows us to make plans for what are we going to do when these families have their child born. And they typically will require, given this diagnosis, a 3-stage surgical process starting within the first few days of life.
Okay. As I mentioned earlier in our introduction, not all types of congenital heart disease are going to have a form of cure. And is that going to be the case with this, or will 3 surgeries cure the infants that are born with Hlhs?
Yeah, it's a great question. And so most families that are born or that have this diagnosis quickly learn that the 3 open heart surgeries are really the best we can do today to be able to allow that right side of the heart function for the whole body circulation. The 3rd and final surgery is the Fontan surgery, which is typically done 2 to 3 years of age. The concern after that is that we're now destined to live with that right side of the heart, the low horsepower engine of the heart, and it frequently leads to a failing heart at some point. Despite our best care, this is really the motivation for what our program focuses on, is how to make that heart bigger and stronger so that it can sustain a normal workload for the normal lifespan.
Absolutely. Along with having heart failure as an ultimate bad complication, are there other things that are also these families will be dealing with along the way?
Yeah, and it's an important question for families to have with their doctors and along the process, because there's so much that goes into this. It's difficult in a half an hour, or difficult with a web page, or difficult to be able to educate the families with all of the sequential process that they go through. But families tend to recognize the 3 open heart surgeries that are needed. They tend to at some point realize that there's liver complications and GI complications that we have to be aware of. Some families are surprised to hear us talk about that because they haven't heard that yet from their doctors. But those are the types of things that, as every child is unique, every child is different, and as they go through this long care process, they learn that there are other things other than the heart that can contribute to problems that need specialized care.
Awesome. I want to talk a little bit more about this and later about ways that you are developing to help with the monitoring for these complications as the child gets older. So we'll come back to that one.
Sure.
So you are the director of the Todd and Karen Wanick Family Program for Hypoplastic Left Heart Syndrome. Can you tell us what this program is and what's your goal as part of and aims as part of this program?
Yeah, so I have the great privilege of working with a large team of people here at Mayo and across the country now that we'll talk more about. But really where it started with the Todd and Karen Wanick Family Foundation that invested in our capacity to translate new technology into new therapies. And that's what we've been doing since 2010. And as some of you know, we've grown quite dramatically with new clinical trials and other activities. But the inspiration of this was really families that have the unmet needs and live with the fear that what happens when their heart does undergo a failing process. What do we do then? And so our program and our team of people, of physicians and scientists, are working to find the new therapies. So it spans the spectrum from basic genetic research to imaging research to stem cell biology, all the way to preclinical and clinical trials now, where we've actually been able to move technology from the lab into clinical trials, which I'm sure we'll talk more about.
Yeah, absolutely. So you mentioned that you started here in Rochester, but you've been able to expand the reach and of other sites across the United States, and that has now been titled the HLHS Consortium.
Yeah.
Can you tell us a little bit more about that?
Yeah, it's like what we're doing today, then that it's awareness and it's bringing people together to focus on rare congenital heart diseases, which doesn't get the airtime that it needs more often than not. And like every institution, we don't have enough patients in one single institution to be able to make a dramatic difference with the research and that's needed to go on. So we've banded together with like-minded organizations that are able to bring centers of excellence together and have more families across the country, not just here in the Midwest, that are working in this program. And we can't do what we do scientifically without the participation of families. And so that was really the inspiration to take the program to as many centers as we can across the country to engage more families.
Absolutely. So what organizations have become involved in your consortium?
Yeah, so Children's Hospital of Philadelphia was the first partner that came on board with Mayo Clinic in our consortium. We now have Children's Hospital of Los Angeles, and we have Minneapolis Children's that has joined in the Midwest region here. In addition to that, we've had a long-standing partnership with the University of Oklahoma, where we have launched and done our first clinical trial for the most part. And so we have been doing multi-center clinical trials now for 4 years, and now we're expanding it to this consortium to have multiple institutions across the country.
Let's talk a little bit about those preclinical and clinical trials that you have going on that are starting very early with infants, right?
Yeah.
At birth. Let's hear about those.
Yeah, maybe the one we can start with is talking about the umbilical cord blood clinical trial, and because we have some exciting news of what we've recently completed and where we're going, and we do have a video that maybe we can show that will set the stage of how we do that.
Absolutely. Let's take a look at that video. So what we have going on here.
So this is the video that demonstrates the important part of the process of collecting cord blood from the beginning and being able to collect and process and store that cord blood to be able to have it ready for our clinical trials. And so this video is walking us through the simple process here of what we do in the lab after the video is, or the cord is collected and how it's processed. And essentially what we're doing here is we're freezing a very highly concentrated product that allows us to thaw it and deliver it into the heart muscle at the time of the second surgery. So these cells can be frozen and they're just fine in low temperatures until, as shown here, the second stage surgery where the cells are thawed and directly injected into the heart muscle during the stage 2 surgery. It's important to realize that these cells that we're injecting are really should be considered as fertilizer that are attempting to go in and allow the heart muscle to grow stronger.
Yeah, great. So let's start with how you guys came up with this trial. So the preclinical and how you made that transition over into the clinical trial while you're actually injecting these into the heart muscles of infants.
Yeah, it's a great question. So it's obviously the critical partner in these clinical trials is the FDA, and being able to do the preclinical work in a sufficient way to demonstrate the safety of these products is the first step that we care the most about, and that allows us to do it in our research lab and do the testing on that. Once we can get through the confidence that this is safe, then we ask permission from the FDA to begin doing this the first time in our patients, which is obviously a big step, and is the most important part of that process is how confident we are in the safety of it in our preclinical laboratory studies.
Okay. So you mentioned umbilical cords, blood. Are these stem cells? And if they are, what type of stem cells are they?
Yeah, it's a great question. And I think the word stem cells can be really misleading to a lot of people. So I think we should spend a bit of time thinking about what that word means.
Absolutely.
In terms of this study that we're using, we're collecting cells from the umbilical cord of babies at the time that they're birthed. It's the only opportunity we have to collect it. And we call them stem cells because the cells are able to grow and divide and are able to do special things of contributing to new tissues. But there are other types of stem cells that people frequently can confuse it with, specifically embryonic stem cells, which are used in some research studies, not in our studies and not in our research, but people will sometimes think of that. Adult stem cells that we use in adult medicine, and there's even bioengineered stem cells. And all of these cells have different strengths and different weaknesses, pros and cons. But in this particular study, we chose to use umbilical cord cells because it could be from the baby's own body.
Okay. So those are called autologous, and then there's also going to be allogenic.
Correct.
Can you explain the difference between those two types and what would be the benefit of having autologous cells that are going to be injected into that heart muscle?
Yeah, so these babies tend to be patients that will end up needing a transplant at some point. We recognize that that's a common outcome of these children. And part of the major limitation of transplant is the body's antibodies that are in the person's body that prevents organs from being a good match for themselves. And so we have taken an approach that we feel strongly about, that we are trying to avoid any allogeneic cells or cells from somebody else's body, because there may be an unknown risk of how that could create antibodies and ultimately have an issue for transplantation down the road. So it's a bit of an extra effort. It's a bit more involved. It's a bit more complicated because we have to collect it at the time of birth.
Okay.
However, we think that the benefits of that may be important to take that challenge on.
Okay, so there's going to be a lot of planning early on. So as soon as the parent and the family gets the diagnosis that their child has HLHS, while the mother is still pregnant, you're going to have to start planning this umbilical cord collection process and down the road where you're going to incorporate it in with your procedures.
Exactly.
Okay. How do families become involved with that process? How do they reach out to you? Yeah,
it's a great question. So the email address is always the best one for us, and it's quite simply HLHS at Mayo, Mayo.edu. So HLHS at Mayo.edu is a great way for anybody to connect with us on any of these questions. And I think today and other opportunities to get the message out, it's important for people to realize no matter where they're listening to this message, anywhere in the country, we have the ability to collect and process the umbilical cord blood from any patient with HLHS anywhere in the country. And by connecting with that email address, we can help walk through that process.
Okay, fantastic. But you need to have that planning early on to be able to get these autologous stem cells.
Yeah, and most of these babies will be diagnosed in utero, and most of them will give us a ability to put a plan in place of what is your plan for the cord blood. And there is other options that we'd like to talk through and make people aware of what those other options are. But these families do need to have a plan for what they're going to do with the cord blood, and we would like to help educate what those options are.
Absolutely. With the allogenic stem cells, is the family or the patient going to need to be under some type of immunosuppressive therapy if they're getting stem cells that are injected back into them versus the autologous ones that you guys are using in your study?
Yeah, and that's the balance between autologous and allogeneic. If you use somebody else's cells, they not only could cause antibodies or a rejection response, but they also might need to have immunosuppression drugs depending on which cell types are used. That might be where the technology leads us because that might be better. It might be the right thing to do, but we don't have the confidence today that is. And so we're focusing today on testing the autologous cells to make sure that we know how safe and effective those are as a starting point.
Absolutely, and so it may minimize the risk of them developing antibodies, which could then in turn affect their ability to undergo heart transplant in the future?
Exactly.
Okay, because if they have antibodies, that may be harder to find an appropriate heart.
Exactly.
Is that correct? Okay.
Finding hearts for these children is a challenge to start with, and so making it even more complicated with additional antibodies is something we're striving to avoid.
Okay. So you said that anywhere in the United States they can do the umbilical cord collection. Would they need to come to one of the heart consortium, the Hlhs consortium sites to be able to do these procedures?
Yeah, that's a great question. So we can collect cord blood on anybody anywhere in the country by sending out a kit and collecting the cord blood, getting it back here, processing and having it available for the immediate studies or even future studies. So we encourage everybody to consider this as an option because we can do it with our program. We have the funding to do it, and we would do that to keep it available for those families whenever they would need it. However, it also is true that the clinical trials where the cells are delivered are done at very specialized institutions. You can't do that anywhere, and that our plan is to do it within the consortium as we go forward.
Absolutely. Well, what other clinical trials has the Hlhs consortium been involved with or are planning to be implemented in the future?
Yeah, one of the ones that we're super excited about is, we talked briefly about it last year, I know, is our interstage home monitoring platform with the digital electronic platform that we've now continued to refine and make it available. So the consortium hospitals that are part of this like-minded centers of excellence are also going to be able to have a digital on an iPad or iPhone application to be able to track the baby's weight, heart rate, feeding, and oxygen saturations, which all of these families know what I'm talking about when they go through this. But it's typically a paper and pencil writing it down and calling the nurse once a week. We now have a process that we're rolling out within the consortium where the families will take this home, collect the data, and it's shared with the hospitals, and the hospitals can see it, and it allows a more bi-directional communication with these families at home to bridge the care, if you will, even after the families go home from the hospital.
And that monitoring and having that data is going to be so important in determining if there's any other complications that are happening and planning for other surgeries. Is that right?
Exactly.
Okay.
You know, simple things of just how well the baby is growing and the body weight that they're gaining is sometimes a really important parameter, and having that data collected in a centralized way is important, but perhaps even more importantly, we can compare it to the families across the country and have a much bigger data set to be able to know, is this a good thing or a bad thing, and how do we anticipate problems better in the future is really a major goal of this platform.
That's fantastic, and I'm sure the families are grateful to be able to contribute to ongoing research to hopefully change the lives of children in the future, give them hope as well. Speaking of the families, you had mentioned earlier, we can't do this without the families, and we can't do this without the support of the Todd and Karen Wannick family program. Let's talk about maybe one specific family who was really, really important in pioneering this.
Yeah. And, the families are banded together in larger organizations, and one of them that is part of the consortium is Sisters by Heart, which is a group of mothers that have banded together, led by Stacy Lynn since early 2010. And they have grown into a nationwide network of support that allows these families to connect, which is so important when families go through this. But within that, we've also been connected with specific families that are the pioneers for these studies. And one family we recently talked about in our blog was the Rubeck family, and Roman, as we published in our blog, was really the family and the individual that was the pioneer, was the first one to be involved in the clinical trials. And there's something special about these families that are willing and able to participate and partner with us to do this for the first time. I can tell you very personally, being involved with this myself, that it's an intense moment to be able to consider what is it going to take to be one of the first to do something that's never been done before.
Right.
And we're so grateful for their trust in us and their willingness to participate in these studies. We literally could not do it without these families.
That little guy's smile makes just everything worth it all the time.
Absolutely.
And everything. I just love his little chubby cheeks there. I just want to kiss him. So I really loved this description underneath that blog article about this family. The first one's to take the risk of hope for a bright future. And it's not a corny phrase. It's really absolutely true, and it brings tears to my eyes thinking about what the family went through and taking that step, and the questions that they asked you about if they were ready to take the step and be the first family. Absolutely. Well, we can't thank the families enough that are involved with this, and that want to help push forward medicine.
And it's not just the first child that gets involved in these things either. It's the whole family. We've recently now completed the 10 patients in this first study, which is something we're super excited to announce and communicate. We are currently in the process of doing the analysis of that first 10 patients. And we're optimistic that that's going to lead us to the phase 2 of this study, where we can bring it to many more patients and further test how efficacious or how effective this therapy can be. So we hope in the next year we're going to expand it so that we can begin to really document how effective this therapy is in making the heart stronger. And if that proves to be what we hope it to be, that's the pathway forward to making this available to all families everywhere.
Okay. So when we think about FDA approval process, there's phase 1, phase 2, phase 3, and phase 4.
Right.
Phase 2, what does that mean specifically for families? Will it be anything different or more access to it?
Yeah, so we anticipate it to be somewhere between 50 and 100 patients that will be needed to be involved, which expands quite greatly from the 10 that we've been working on for the past few years. So it increases the demand for us to find ways of having effective partners across the country, getting more cord blood collected. Those are not trivial challenges to be able to make this happen. But then the goals of that study will be to prove, or to test at least, how effective it is. Can we actually make the heart muscle stronger with this therapy? The first phase of the study was to make sure we're doing it safely, make sure we weren't having complications, and that was the intense focus.
Okay.
The phase 2 will be much more focused on, does the heart actually improve, and can we make the lives of these patients better? And that's why we'll need more patients to be involved.
Okay. Do you know what kind of things you'll be measuring to see if the heart is improving?
Yeah, they'll be similar to the echo and perhaps even MRIs from a cardiac imaging standpoint, but other things of body gain, the body weight gain, things like this that are also important measures of the baby thriving are all the measures that we'll be looking at very carefully.
Excellent. As part of the consortium, you guys will be also expanding out some of the other areas of research focus that the Tana and Karen Wanick family program has been using. Can you talk a little bit about those, like the biorepository and imaging?
Yeah. So basically the whole infrastructure of our program for the last 7 years formed out of Rochester is also going to be available through this consortium site. And so it's not just engaging families at the other sites, but it's engaging the scientific expertise and the clinicians at these other sites to be engaged with defining the problems, inventing new experiments, and trying to find new therapies that maybe ourselves wouldn't have thought of in isolation. And so it's the whole network of research that we're bringing to the consortium is what we're aiming to do.
Okay. We have a great patient question here, and they're asking, what is being done, or is it part of the consortium to be looking at some of the liver complications that we do see as part of the Fontan pathology? Is that something that you guys have included in your reach yet, or is that something in the future?
Yeah, it's a great question. And so many of the families that may be watching realize at some point in their care pathway that their doctor will mention the word liver and your liver's not normal. That's very, very common for these families, and because of that and those complications, we do have ongoing projects that we're making an increased focus on today of trying to understand that pathology, what goes wrong with the liver, and ultimately what can we do to make it better. And I hope in the coming year we'll have some exciting new understanding and announcements on what we can potentially do in that area.
Awesome. I look forward to hearing about that. Maybe next year around this time we can talk about those things more as well. We have another audience question, and this is one thing we didn't get into in the beginning, but they want to know if there is any kind of genetic link, any sort of research is going on to look at what is causing HLHS, and is there a link between that and other genetic disorders? Is that something that the consortium or your program is involved with?
Yeah, it's a great question again. So we do believe that there is a genetic underpinning to this syndrome. It's going to be different for every family, is what we've learned. Dr. Tim Olson and his team and the genetics research side housed out of Rochester here are very intimately involved on a day-to-day basis of trying to understand this. We've published a couple of things. We have some insight of some genes that are linked to it, but we also have an expanding network of physicians and scientists working to model the disease and even fruit flies of all things so that we can...
That's what I did in genetics back in college. Yeah, sorry.
So even knocking out these genes and understanding if those genes have an effect on a fruit fly is teaching us and educating us to understand which genes are going to be important as we go forward.
Wow, this is really, really exciting stuff, and I'm looking forward to hearing more and more as you guys continue to expand your program in the future. Do you have anything else that you wanted to share with families about support groups or research that's on the forefront and coming out in the future?
Well, we're just so excited about the expanding awareness and expanding team that's growing from this, and we couldn't do it without the Todd and Karen Wanick Family Foundation, the commitment and support of Mayo Clinic, and the families across the country that are part of this. And we're super excited about how that increased focus and energy of families across the country are going to continue to find new pathways forward. And we're very optimistic that there's a brighter future of how we take care of these kids in the future based on this type of activity.
That's really exciting. Thank you for taking the time to share what's going on with the program today. And thank you everyone who watched. That's all the time we have, so please join us next week on February 15th at 11 a.m. Central Standard Time for our next video Q&A, Ask the Mayo Mom. Our guest will be Dr. Karthik Balakrishnan, who is a pediatric ear, nose, and throat physician who specializes in reconstruction of airways of infants and children. Please join us then, and feel free to send any questions in the future. Thank you everyone who joined our conversation today. Have a wonderful day.